So folks, hi, my name is Dr. Anita Bhola. I'm a sleep specialist, and I'm the medical director of the sleep lab here for St. Luke's Cornwall Hospital. Our original sleep lab is in Cornwall, which I've been sort of managing since 2009. And now we have another lab in the Fishkill location, which I also direct. So I'm going to be talking this evening on some common sleep disorders. And please, if you could refrain your questions till the end, I'd be happy to answer each one of them. So I'm going to try and make this as simple as possible. And if there's something you don't understand, go ahead and jot it down and we'll address it at the end. All right, so I don't have any conflicts of interest to disclose. And I want to start just by saying that, as you are aware, we do spend almost a third of our lives sleeping, but our health during wakefulness is impacted. The 2/3 that we are awake is impacted by the 1/3 that we spend sleeping. So why is sleep important? I'm going to cover a few of these topics. Why is sleep important? What is good sleep? What are the common symptoms of sleep, the common sleep disorders? I'm going to talk about what are common sleep disorders in the general population versus those that present to a sleep center or sleep lab. And then I'm also going to be going over sleep disorders that are secondary to other causes. So I'm going to start by just, going over what you probably already know. And this is like, why is sleep important? Because as you know, this is when we rest and relax, and this is when the body is healing. There's a lot of metabolic functions that do take place during this time, such as removal of toxins, body temperature regulation, etc. And then a lot of hormones that are released or actually are decreased during this time. So for example, growth hormone is released during sleep. And so when there are sleep problems in kids, growth is stunted. Also, there is a decline in the cortisol level and the insulin level. Our immune defense function is impacted or built up during sleep. And then, as we know, learning and memory is consolidated during what is called REM sleep, rapid eye movement sleep. And most important, we dream during sleep. So sleep really is one of the pillars of good health. It is essential to life and health. So what exactly is good sleep? Now, good sleep is not just the quantity of your sleep, but it also depends upon the quality of your sleep. So, I don't know if most of you are aware, but the average adult needs roughly about 7 to 9 hours of good quality sleep to feel rested and alert the next day. So not only is the quantity important, but the quality also should be good. And what is good quality sleep? It's deep sleep, what we call stage N2 and 3 and REM. And sleep is good quality if it is continuous rather than fragmented or sort of chopped up. So here are some of the common symptoms of sleep disorders. You must have heard about most of these. Patients or their spouses will bring the patient in, and there is the symptom of snoring, or my husband stops breathing. He has breathing pauses during the night. He can't wake up in the morning. You're tired during the day. You end up taking naps. Sometimes patients end up falling asleep at the wheel and end up with motor vehicle accidents. Then there are other symptoms of sleep disorders, which pertain to insomnia symptoms. For example, patients will say they can't fall asleep, they can't stay asleep, they wake up frequently, they wake up too early and are not able to resume sleep. Other patients may report uneasiness or discomfort in their legs, and some patients will report, vivid dreams, and a lot of times they will report dream and acting behavior. So they're in a dream sequence and they feel like they're chasing somebody with a sword. So here are some of the common sleep disorders. What we see in the lab is really obstructive sleep apnea. This is probably the most common one. Insomnia is an extremely important sleep disorder, followed by restless leg syndrome. There's something called narcolepsy, which I'm going to just briefly touch upon. And then there are these clock misalignment disorders, which are called circadian rhythm disorders. One of them is what we see in night shift workers, and jet lag is also an example of a circadian rhythm disorder. There are what are called parasomnias, and these include sleepwalking, sleep talking, and a condition called REM sleep behavior disorder, which I'm going to go over. And then I'm going to just quickly touch upon sleep in the elderly and sleep-related issues during COVID-19, a very, very important topic, and then wrap up with talking about sleep deprivation and what constitutes good sleep hygiene. All right, so the most common sleep disorder in the general population is insomnia. About 10 to 30% of patients in the general population will suffer from insomnia. However, patients presenting to a sleep center, most of them present with symptoms of sleep apnea. So what are some of the other causes that will affect sleep? If you're in pain, that'll affect your sleep. Anxiety, depression, stress, certain medications, use of alcohol or substance abuse or nicotine close to bedtime, these can all affect sleep. So any illness can cause a sleep disorder, but any sleep disorder can actually cause illness. So this is sort of like a bi-directional relationship. All right, so I'm going to start by addressing the most common sleep disorder that we see presenting to a sleep center, and that is obstructive sleep apnea. And in this condition, patients will typically present with symptoms of loud snoring. The bed partner might say that the patient, that my husband stops breathing at night. There are these breathing pauses. It can be pretty scary to a bed partner. Sometimes patients will wake themselves up, gasping and choking during sleep. There are frequent awakenings, which are unexplained. Sometimes you wake up several times to use the restroom. Waking up the next morning, you just you're dragging. Patients will typically report, I'm tired of being tired. They'll be falling asleep at their desk, and so on and so forth. There could be drowsiness while they drive, but also there are some mood changes that occur when patients have sleep apnea for a long time. And remember, this is a chronic condition. This is not something that happens from one day to the next. This has been brewing for probably several years. So patients could be irritable, they could develop anxiety and depression. Your memory could decline, and this is something that we see pretty often, patients reporting memory decline, and we'll often get patients that are referred to us by the neurologist, which is where patients are referred typically for memory decline. There could be a loss in productivity, because you're just not alert enough. Patients start using a lot of stimulants like caffeine or nicotine or energy drink like Red Bull and Soma, etc. They may wake up with a dry mouth, sore throat, morning headaches. And as I alluded to just a minute ago, there is increased frequency. So patients will wake up several times to urinate at night, which could be from other reasons as well, but it certainly could be from sleep apnea. And then in terms of libido, there is a decrease in the sex drive. Obstructive sleep apnea can be associated with a drop in the testosterone level. And then just overall, there is poor quality of sleep. But, here is a cartoon of somebody, a wife who's like, unfortunately, she has to stay awake because the husband is snoring so loudly. And this can also be disruptive for marriages. So, one of the bed partners may end up and leaving the room and going to another room to sleep. And that causes some friction in the marriage too. So, apart from the bed partner using earplugs, which could be the foam kind, the kinds that you get, you can buy this pack anywhere, or the waxy kinds that swimmers, use. So earplugs for the bed partner could be helpful. But let me just go over, I think I'm missing a slide here. Yeah, I'm sorry. Could you show me how to go back previous? All right, previous. All right, sorry about that. Yeah. So I just want to go over some of the risk factors for sleep apnea. So we know that sleep apnea will classically occur in somebody who is obese or morbidly obese or has gained weight. Sometimes just 5 pounds extra can sort of tip you over the edge. is right at the top of the list. But sometimes even if you're not really obese, but you gain just 5 pounds, that can tip you over the edge. We know that a large collar size, so men who wear a shirt collar size of greater than 17, that could be a risk factor for sleep apnea. If your nose is obstructed, you're not able to breathe through your nose for some reason, maybe you got a polyp, maybe you have allergies, maybe you got a deviated septum, that could certainly be a risk factor for sleep apnea, because it's really an obstruction to your upper airway. In kids, we see large tonsils causing sleep apnea. And it's pretty dramatic, because once the ENT doctor takes the tonsils out, the sleep apnea often will resolve. Just in general, having a large tongue is a risk factor. And underactive thyroid is a risk factor. So is smoking. So smokers almost have like maybe a 6-fold higher risk of getting sleep apnea. And this is because smoking can make the back of the throat or the upper airway sort of boggy and swollen, and the passage through which the air has to pass into the lungs becomes narrow. And then sometimes we'll hear about a family history. So patients will say, oh, my father had sleep apnea, or my brother uses the machine, etc. Now, I write pregnancy, and I put pregnancy down here, but I just want you to take this with a grain of salt. It's literally to some degree only because pregnant women can gain, volume or fluid in their bodies, and sometimes the nose becomes a little narrowed. With the weight gain, there can be some degree of sleep apnea, but when you lose the weight and the baby is born, that can resolve. So I don't want you to take home that, pregnancy is a risk factor as such. It's really not. Now, if sleep apnea is left untreated, here are some of the bad things that can happen. These are what I call comorbid conditions. We see this pretty often. One of them is high blood pressure. So fairly high association between high blood pressure and untreated sleep apnea. And in fact, if you have a patient who's on more than 2, 3 medications, and their blood pressure still isn't controlled, a condition called refractory hypertension, your doctor or whoever's managing your blood pressure really should be asking, whether you snore and you have breathing pauses, and whether you have daytime sleepiness, and they should refer you for sleep apnea testing, because there's a very, very high association between refractory hypertension and untreated sleep apnea. Now, sleep apnea can also lead to diabetes. It can lead to a whole host of heartbeat irregularities, which we call arrhythmia. So the heart rate could be slow, the heart rate could be fast, but this condition called atrial fibrillation is pretty strongly associated with untreated sleep apnea. And so is heart disease, just basically, having a high pulmonary pressures or just having heart disease, congestive heart failure can be associated with untreated sleep apnea. So is stroke. So the association between stroke and untreated sleep apnea is almost like 40%. And then, as I alluded to earlier, there can be memory loss, and there've also been studies talking about the association of untreated sleep apnea to developing Alzheimer's dementia in some patients. We talked about the fact that there can be accidents. It could be like a train accident, could be a road accident, it could be somebody carrying a weapon because that's what their job entails, like cops do, where you're just not vigilant enough. So accidents can happen from sleep apnea, and I'll go over why that happens. And then lastly, there can be perioperative complications. So when you're admitted for some kind of surgery, there can be complications if you have sleep apnea and it's not detected previously. So what exactly is sleep apnea? So here is a schematic of somebody who's breathing in through the nostrils, or even if they're breathing in through the mouth. You see the tongue over here, and you see the soft palate, how elongated it got, and the tongue is large. And when this patient falls asleep, our muscles relax when we fall asleep, and the tongue is a muscle, and so is the soft palate. And if your tongue became large because you gained weight, and believe it or not, the tongue has fat cells. Even though it's a muscle, it has fat cells. So if somebody gains weight, their tongue could become larger. Now, a bigger, fatter tongue, when it relaxes at night, it basically drops down and it pinches or closes off the airway. This is what is called obstructive sleep apnea. And what it's doing is it's really cutting your air supply, not the oxygen, because it's cutting all the air supply, which contains oxygen, by the way, and it prevents it from transiently going down the windpipe into the lungs, and therefore the oxygen level in the body will episodically drop. So we see this, we see episodes of hypoxemia, which is drop in the oxygen level. We'll see recurrent episodes of upper airway obstruction. So the gasping and the choking and the breathing pauses and that funny kind of sound, that's when this happens, when this obstruction happens. And what this typically does is, this is like a stress response. So when your brain notices that the oxygen level in the body has dropped, the brain, being our smartest organ, will not allow us to go into deep sleep or even continue to sleep. It's going to arouse us or waken us several times, or even just recurrent arousals, which are very brief awakenings. And this kind of chops up your sleep. So even if you're sleeping 8 hours, it's 8 hours of fragmented or chopped up sleep, which then leads to a state of sleep deprivation, because it really feels like you've slept only 4 hours or 5 hours. So imagine if that's happening night after night after night for several years. What it can do to your mood and your personality, et cetera, and anxiety level. And here is so the way we diagnose sleep apnea is by either calling the patient for an in-lab sleep study. It's called a nocturnal polysomnogram. And this is really the gold standard of how to diagnose sleep apnea. But there is the option of a home sleep test, where we send you a box and a few attachments and with a link on how to use this. The home sleep tests are not as accurate, but at least it's the second best. So here is really a schematic of somebody breathing in and out, and here the tongue fell back, and you can see that the tracing became flat. So we're actually, during an in-lab study, you come in at night, the technician will place a bunch of electrodes on you, and you'll sleep with these. There are no pins and needles, so it doesn't hurt in any way. It's just that you have some electrodes, small electrodes placed with glue, and the next day when you shower, all of this comes off. But we're actually monitoring a number of physiological parameters as you sleep. We're measuring your oxygen level, and here in the blue, we see that when the airway collapses, like you see in the red, the oxygen level at the finger, which is the pulse oximeter, drops. That's a no-brainer. And also, we see these arousals at the brain level when the airway collapses, because the oxygen level dropped down and your brain kind of woke you up, and you see these squiggly lines. So this is how this is the gold standard of diagnosing sleep apnea. Now, I just want to warn you, there are a lot of snoring devices out there, and every time you open Amazon or any other internet company, somebody is talking about using a dental device, or one of these chin straps, or one of these little prongs that you can place in your nostril, or even these breathe right strips. And they may be okay for snoring, but they're not okay for sleep apnea. And I just want you to take home this message that not everybody who snores has sleep apnea, but practically everybody who has sleep apnea snores. So snoring should be taken pretty seriously. So the actual treatment of sleep apnea is with the gold standard is with a CPAP or a BiPAP machine. This is nothing but and you can see this woman sleeping with a machine by her bedside. This is a CPAP or a BiPAP machine. She's breathing through a mask, which could be light nasal pillows or a full face mask, which is connected to the machine through a hose. And the machine is not giving her oxygen. It's literally compressing the room air and delivering air under pressure. And that air under pressure will splint open the airway. It'll get the tongue and all the muscles that are sort of caving in and collapsing, it'll get them out of the way. But then, depending upon your degree of sleep apnea, you could also be a candidate for what's called a custom fitted oral appliance made by a dental sleep specialist. Here is an example of one. We typically refer you, and I would caution you not to go to any dentist for this. There are certain indications for these custom fitted oral appliance. It doesn't work for moderate or severe sleep apnea. It might work for mild sleep apnea. And then ENT surgery. So we could refer you to an ear, nose, throat doctor who could actually then, make some more room in the back of your throat. And you see this patient, their uvula was sort of taken out. And this is called a UPP, which is a uvulo-pharyngoplasty. There is something called Provent. These are like these little blister kind of things that you put over your nostril, and they create like a little pressure through microvalves. Not super effective. And I'm going to go over what's called Inspire therapy. It's been in the news quite a bit, and a lot of patients ask about this because it's on television and radio. And then weight loss, absolutely important. Never mind what kind of mode of therapy, you have to do something for weight loss. And I forgot to mention positional therapy. So here's a man sleeping with, unfortunately you can't see it, but this black styrofoam filled sort of a belt, which he's wearing around his chest, where the styrofoam filled part is literally on his back. It's keeping him off his back. And this sometimes works for mild sleep apnea, where your sleep apnea gets worse when you're on your back. Avoiding alcohol, avoiding anything that is a muscle relaxant, stop smoking, improving sleep hygiene, and avoiding sleep deprivation. Now, I want to just take a second to mention about marijuana use, because somebody asked me this question at our last virtual talk, which is for the Cornwall Library. There has been some talk about certain synthetic marijuana. Could it there's been very, very few studies in animals and a few human beings, which may have shown that it could potentially improve cause a modest improvement in breathing during sleep in patients with sleep apnea. However, this is not ready for prime time. It actually has not only has not been validated, it hasn't been approved by the FDA, and also it can actually make your daytime sleepiness worse. So I would absolutely caution to stay away from this. Okay, now I want to mention something that just came up last month, and it has to do with the recall of Philips Respironics machines. So most patients who have a CPAP or a BiPAP machine will either have, Philips Respironics machine, which is probably the largest manufacturer of machines, or they'll have a ResMed machine, which is an Australian company. These are probably the two most common manufacturers. And the latest model of the Philips Respironics machine is called the DreamStation. But now they've come up with what's called DreamStation 2. So last month, there was a voluntary recall by Philips Respironics, and it had to do with some potential health risks, which had to do with the foam that they use inside the machine, which is meant for sound abatement. In a very, very small percentage of patients was found to have sort of produce particles which could be inhaled or even gas off. So what is Philips Respironics really doing about this? What they're doing is, firstly, it's important to know which devices are affected. So I've put here a toll-free number and also a link that Philips Respironics has advised patients to sort of go to and report or register their machine immediately for either replacement or repair. Now, this is only for Philips Respironics machines, not for ResMed machines. Understand that the risk is extremely low. It's like 0.03%, but Philips basically has put these machines on recall, which is a huge, big problem because, there are patients who've got moderate or severe sleep apnea. There are patients who are bus drivers who have sleep apnea. How do you tell them to stop using their machine? It's a really, bad situation. However, hopefully, the first step, of course, is to register your machine for replacement or repair. And I think the site also tells you which devices are affected. But if you have any of the newer, if you got your machine, let's say in the last 5 years, they have been giving out the DreamStation. If you got your machine in the last couple of months, it's possible that you could have gotten the Dream Station 2, which is not on recall. I repeat, not on recall. So Philips is recommending that patients discontinue the use of their machine and consult their physicians to determine whether it's okay to continue using it or stop using it. So they want us to decide whether it's beneficial or is it risky to stop using it. I think that's a huge responsibility, but what I would suggest is that if you have one of these machines, please make an appointment to have a follow-up visit with your physician, your sleep physician. And if any of you see me, please call the office to make an appointment, and then we can go over these issues. Because it is not appropriate for everybody to stop using their machine, because it could actually be more risky to stop using your machine, even if it's for temporary, for a short time period while Philips is, getting their act together and replacing or repairing these machines. But they also do recommend not to use ozone cleaning products such as SoClean. They're also recommending that, that if you review the age of your machine, because as you know, machines are replaced or the insurance will pay for a new machine every 5 years. So if you received your machine somewhere in that ballpark and you make an appointment with your sleep physician, we could script a new machine, and you could actually end up getting a non-recall machine, which is a ResMed machine or Philips Respironics Dream Station 2. Also, if you go to this website, it'll tell you how to find the serial number of your machine. All right, so now this is about Inspire therapy. This is a small pacemaker-like device. It's a metallic device that is placed under the collarbone. And it's typically meant for patients who are CPAP intolerant and not super obese. So if somebody is morbidly obese, they may not be a candidate for this. And also it's meant for patients who have moderate or severe sleep apnea, not for mild sleep apnea. And it's typically for patients who've tried using the mask and the machine and they just couldn't do it. So one of the good things about Inspire is that there's no mask, there's no hose, there's no machine, but you have to go through a referral to a center that actually does implant these. These are implanted by ENT surgeons. And there are certain centers where this is done, for example, White Plains Hospital or Montefiore in the Bronx or Hackensack. So they have ENT physicians who may be trained in Inspire therapy, which has been around for a while, and it is FDA approved. So first they would evaluate you by doing giving you some sedation and doing an endoscopy. And if you are a candidate, then they would call you in for a same day procedure where they would implant this surgically. And this little pacemaker-like thing has a couple of wires that go, one goes to the base of the tongue and it stimulates the tongue. Basically, the patient sleeps without anything on, but with the remote. So when you're sleeping, you basically would be turning the remote on, and that would stimulate the tongue and get the tongue out of the way. So that's how it works. If any of you need any information on it, you could go to inspiresleep.com. I repeat, inspiresleep.com. All right, so switching gears, we'll briefly talk about insomnia, which is the other major sleep disorder. And it's characterized by patients reporting either difficulty falling asleep, or they have difficulty staying asleep, or they're waking up too early and they're not able to resume sleep. Now, these symptoms may either be short-lived, which is called acute insomnia, and it could happen, let's say you lost a loved one, or it could be chronic. So I'll have patients who'll say, I've had insomnia since I was in high school. But it really causes non-refreshing sleep. So patients don't feel rested the next day, and they're not able to sleep despite giving themselves adequate opportunity to sleep. So if you're putting yourself in bed only for 4 hours, that's not insomnia. That's just sleep deprivation. That's just voluntary sleep deprivation. But if you're putting yourself in bed for a good 7-8 hours and you're only able to sleep 50% of that, that could be insomnia. So some of insomnia is primary, meaning there's no cause. Patients are just light sleepers, or they've had this condition for a long time. Their mind just wanders when they're sleeping, but it often is a symptom of some other underlying condition, such as depression, anxiety, or pain. And as you see from this graph, the incidence of insomnia goes up with age, and it's really highest in women. It's more, so the orange bars are women and the yellow are males. So it's much higher in women, especially in their 70s. So we started by giving the patient a sleep diary. This is from the American Academy of Sleep Medicine. You could just Google it and download a AASM, American Academy of Sleep Medicine, sleep diary for yourself. And it really tells you how to fill this out. It's a self-reporting of your sleep habits and patterns. And as you can see, you know, the patient, these gray areas are where the patient sort of shades off, which is when they think they're asleep. And typically they'll bring this back to the physician for review. But a lot of patients are actually using these consumer tracking wearables like Fitbit, Garmin, et cetera. And I have patients coming to me and saying, oh, here is my data. They'll show me their smartphone with their data and look, I didn't have enough REM sleep or deep sleep. So understand that you got to take this with a pinch of salt. I mean, they're not bad, but can they detect REM sleep from non-REM sleep? I don't think so. But it's not a bad tracking tool. Most of the causes, okay, here are some of the causes of insomnia. So there's a bunch of medical conditions such as COPD, acid reflux, you know, fibromyalgia is a common cause of insomnia. I mean, your body is hurting. If your body is hurting, you can't get comfortable. If you can't get comfortable, you don't sleep. But then you also see it with the number of psychiatric conditions, you know, mood disorders such as depression, anxiety disorders can very often cause insomnia, as can alcohol and drug withdrawal. And then there are a bunch of medications that you should be aware that they cause insomnia, so take them in the morning rather than in the evening. One of them is steroids like prednisone. The other one is a beta blocker like metoprolol. So these, if you're taking these medications for whatever reason, take them in the morning, not in the evening. And then stimulants, you know, caffeine has a long half-life. It'll keep you up. If you're prone to insomnia, if you smoke close to bedtime, smoking cigarettes is a stimulant that'll keep you up. And then electronics is a huge big factor in causing a delay in somebody's sleep time. So how do you treat insomnia? Well, I mean, part of it is we try and start off with what's called cognitive behavioral therapy, but understand there are not that many cognitive behavioral therapy experts in the country. And these typically are psychologists who've been trained in CBT. This is actually works much better than medication. But then medications, as you know, there are a bunch of over-the-counter medications and then there are prescription medications. So what exactly is CBT? It's a bunch of, it's a whole series of instruction that you get from a CBT expert regarding good sleep habits, also creating an environment that promotes sleep. You could get a white noise machine. But the behavioral therapy part of CBT is, one of them is stimulus control, which means if you can't resume sleep in a certain amount of time, let's say 30 minutes to an hour, you shouldn't be laying in bed because otherwise you're going to keep associating the bed with sleeplessness. So you should get up, go to another room, and then come back only when you're sleepy. Also, laying in bed, when you're not able to sleep, doesn't help. So restricting your time in bed can help. Progressive muscle relaxation, guided imagery, all of these help with insomnia. And then I just want to mention that there are some online CBT programs. One of them is called Shut Eye. You could look at this on the internet. And then the VA uses an app called CBT Coach, which is pretty helpful as well. So CBT has been considered the first-line therapy for chronic insomnia, and the effects of this actually last longer. Here are some of the over-the-counter medications, but most of them contain Benadryl. So you could have Tylenol PM or Unisom, and most of them will have Benadryl. And I will tell you that if you're in the older age group, you really shouldn't be taking these because Benadryl has a long half-life and will leave you groggy the next day, which can make you prone to falls. So really the safest one is melatonin. There's also another preparation called REM Fresh, which is a melatonin preparation. And here's a whole bunch of different over-the-counter sleep aid. Then there are FDA-approved prescriptions for insomnia, and they fall into primarily three categories. One is the non-benzodiazepine groups, such as Ambien or Lunesta or Sonata. And then there are the benzodiazepine group, which are muscle relaxants, and they're not that safe at all to use. So they're actually fallen out of favor. Excuse me, some of these could be Xanax or lorazepam. And then there are off-label sedating medications such as trazodone or Remeron. Your doctor may prescribe these if you have, combination of insomnia and anxiety/sedation. So, these are all the medications. All right, switching gears, we're going to talk about another common sleep disorder, which is called restless leg syndrome. This is a sleep disorder in itself, and it's characterized by the patient complains of, I have a discomfort in my legs. It's mostly in the legs, but it can occur in severe cases. It can occur in the arms as well, but there's a discomfort or a creepy crawly sensation in the legs. It often peaks in the evening or night hours. It predominantly occurs at rest and improves with stretching or moving. So a classic example would be, somebody sitting on a couch at night watching television and they just cannot sit still. They have to get up and move around. Or you're on a, long car trip or on a long plane trip and your legs are just restless and you have to get up and move. This can run in families. However, a very common cause for this in women especially is secondary to iron deficiency anemia, because women lose blood during pregnancy, but they also menstruate. So women will often have iron deficiency anemia. And, we often check the serum ferritin level, which is a simple blood test. Kids can also get restless leg syndrome. Sometimes when we're doing a sleep study, we will actually see a lot of what we call periodic leg movements on an in-lab sleep study, not on a home sleep study. And seeing these is often associated with restless leg syndrome. Not always, but often. All right, narcolepsy, just literally one word, a couple of minutes on it. It's a condition which is not common at all. It's characterized by extreme severe daytime sleepiness. Sometimes patients have these sleep attacks. They also have severe disruption in their nighttime sleep. They could hallucinate during sleep, or what is called cataplexy, so sudden muscle weakness in response to a strong emotion. So for example, if somebody told a joke and your knees just suddenly buckled or you fell down, that could be, and you have severe daytime sleepiness, that could be a sign of narcolepsy. It's an autoimmune process. It's seen in all ages, but it's typically seen in a younger age group, like around 25. And it has to do with the loss of certain neurons called hypocretin, which actually are responsible for the muscle tone that we have during wakefulness. So how do you diagnose this? Again, you go to a sleep center, you see a sleep specialist who orders an overnight sleep study, followed by what is called an MSLT, or multiple sleep latency test. It's a 5-nap daytime test. And your doctor may, if you are found to have this, you may be placed on some alerting medications. Circadian rhythm disorders have to do with a sort of a mismatch between your internal body clock, which tells you, okay, it's time to go to bed or not, between your internal body clock and the external influences, such as daytime or daylight. And we often see this in shift work sleep disorders, shift workers, like night shift workers, where, they may have problems with sleeping during the day and suffer from a circadian rhythm disorder. We also see it in patients who have jet lag. Parasomnias are, they're basically just undesirable, things that happen during your sleep. It could be some kind of a movement, or it could be some kind of a verbal response that occurs either during sleep or during the transition of wakefulness. Examples of these are sleepwalking, sleep talking, and I just want to mention this disorder called REM sleep behavior disorder, which is patient typically could be an older male and would maybe brought in by the wife who reports, oh, he flails and he hit me several times in his sleep, or he fell down, or he got up and just started, looks like he was chasing somebody. So they're screaming, punching, kicking, and it can sometimes cause injury to the bed partner. So this really needs to be brought to the attention of a sleep specialist who would then order a sleep study. And we're looking for, some abnormality both on the video part of the sleep study as well as on the electrodes that monitor sleep. Why is this important? It is important because 40% of them could be associated with Parkinson's down the road. Just important to bring this to the attention of the doctor. Now in elderly, it's not so much that their need for sleep decreases, they just have a decreased ability to sleep. And this has to do with the fact that there's a lot of other things that go along with aging, such as they're on medications that could cause poor sleep, or they may have medical conditions like arthritis or what have you that could cause poor sleep. So it's not that they have a decrease in the need for sleep, but the ability to sleep is decreased, and sleep is more fragmented. It's less consolidated, and it can actually lead to decrease in your function during the day and cognition, and can result in falls. So that's something to be aware of. Now, this is a very unfortunate thing that happened to us. A lot of patients have suffered from sleep disorders during COVID, and it has to do with the stress and anxiety related to the pandemic and the complications. Basically, patients have lost sleep and have reported daytime fatigue. What also happened is that during these lockdowns, there's been patients suffering from depression, anxiety, and this increases the risk of insomnia. It's a term that's called coronasomnia. Also, staring at screens late at night is implicated in poor sleep. So if you're staring at, if you're always on looking at the television and all you're hearing is bad news, that could be an issue and would keep you up at night. If you're binge watching on Netflix, or you're putting in extra hours staring at your computer screen because you're working from home, that could also delay your bedtime, because all these screens have what is called blue light, and blue light can actually suppress your melatonin levels. So your brain is trying to secrete melatonin at night, but that unfortunately gets shut off or decreases because you're staring at your phone or your computer or your iPad. So that's another reason why COVID has really wrecked up sleep. You're also not motivated to get out of bed. There's no routine anymore. At least there wasn't during COVID. And a lot of patients will have, they may have opted to cope with this with alcohol and substance abuse, and that can only worsen the sleep disorder. So here are some coping strategies, and I sort of mentioned this even though we're hopefully out of the COVID pandemic, or at least I think I'm optimistic that we are, but really getting out and exercising and being out in the outdoors and getting exposed to natural sunlight is very important. Avoiding alcohol and caffeine intake, especially close to bedtime, very important. Putting away your electronics before bedtime, or if you must use them, use a blue light blocking filter. Trying some relaxation techniques. It could be like just deep breathing exercises, or stretching, or yoga, or meditation, or even downloading some of these apps like Headspace and Calm can help with sleep during the anxiety that's associated with COVID. And also limiting your again, we're doing a lot better in the US, but there are parts of the world where COVID is still very rampant. Just keeping watching television, just watch one or two sites and keep it limited so that you're not overwhelmed by all the death and destruction that's happening. So we're at least, glad that as more and more people have been vaccinated here, we're emerging, supposedly emerging from the public health emergency soon. And it's just also important to realize that you're not alone in this. Everybody's gone through it a lot. The sales of sleeping pills had gone up tremendously during the pandemic. And I really, really want you to concentrate on, number one, be aware of this. Number two, start resorting to these other sleep coping strategies so you do not get addicted to medications. And be optimistic. All right. And then also realize that, in this modern society, we overall are sleep deprived. Most Americans don't even realize that they need 7 to 9 hours of good quality sleep. Most of us are sleeping a lot less. And sleep deprivation can also affect your mood and your functioning or your alertness the next day. So here's just a whole host of sleep hygiene, tips. I think I've gone over most of them, but just try and keep the same bedtime and rise time. Use the bedroom for sleep or sex and really nothing else. You shouldn't be like sitting on your bed and, doing anything else. Try to keep the clock away. Don't eat large meals before bedtime. Try not to have your pets in bed. I know a lot of us are actually pretty attached to them. And I'm going to end here. I'm sorry I sort of went over, but it's just such a huge topic. So I thank you for your time. And I just want to mention that, if you do experience any new or worsening sleep disorders, you should contact your sleep specialist. I am at the Cornwall campus. I see patients here in person. And so if you'd like to make an appointment, feel free to. I also see patients virtually for those who'd rather not visit the office. So I'm going to end here and I'll take any questions.